Hello guys, so now we are going to discuss a very important topic which you guys are going to face in the emergency departments also, as if you are working as a GP clinician, so you are going to have this. Also, if you are a medical student, you are going to have this kind of patients in your surroundings. And so without wasting time, we shall start. This is a hypertensive urgency versus hypertensive emergency. So basically this is what it is. So definition of hypertensive crisis is very important. It refers to the severe elevation of blood pressure. Usually the blood pressure is systolic is above 180 and diastolic is above 120. So there are two categories. One is the hypertensive urgency and emergency, and the one is hypertensive urgency. And these are differentiated on the basis of presence or absence of acute target organ damage or end organ damage. So there is a classification. If there is a severe asymptomatic hypertension, BP will be 180 by 120 and there will be no organ damage. Then is the hypertensive urgency. Also the BP is greater than 180 by 120 and no acute organ damage. But the most important thing is hypertensive emergency. Here the BP is above 180 by 120, but there is end organ damage, and BP level alone does not define an emergency. This end organ damage defines. First we will have a topic revision, and then we will discuss how we are going to have the presentation of these kind of patients and how we are going to manage them. If we talk about the pathophysiology, so the normal autoregulation maintains organ perfusion. When BP rises abruptly, there is endothelial injury, fibrinoid necrosis, increased vascular permeability, and activation of renin-angiotensin system and platelet activation and microvascular thrombosis, which results in organ ischemia and organ dysfunction. Okay, so what is cerebral autoregulation? Normal cerebral blood flow remains constant despite BP fluctuation. When mean arterial pressure exceeds autoregulatory range, it results in cerebral edema, hyperperfusion, and increased intracranial pressure. This leads to hypertensive encephalopathy, stroke, intracranial hemorrhage. So if we talk about the hypertensive urgency, here we have already discussed that here BP will be above 180 by 120 and also plus no end organ damage. Okay, so the BP can be above 180 and no neurological defects, no pulmonary edema, no acute kidney injury, no myocardial ischemia. Clinical features of hypertensive urgency are: they may be asymptomatic, the patient has a increased blood pressure. Also, some symptoms can be headache, anxiety, palpitation, dizziness, mild dyspnea, and epistaxis. Okay, so there will be no evidence of stroke, MI, pulmonary edema, acute kidney injury, or aortic dissection. Well, in the hypertensive emergency, there is increased BP plus acute end organ damage, and this is a medical emergency. If it is not treated, the patient can die. Okay, so acute and target end organ damages include the brain, most critical one, the heart, kidneys, eyes, and vessels. In history, we have to exclude all these end organ damages. If we talk about the brain, there can be hypertensive encephalopathy, ischemic stroke, and intracerebral hemorrhage. Talking about the heart, includes the acute coronary syndrome, left ventricular failure, and pulmonary edema. In kidneys, it's acute kidney injury. If we talk about eyes, it's papilledema and retinal hemorrhages. And vessels mein aortic dissection is most important. We're talking about the clinical features of hypertensive emergency. These include the severe headache, then confusion, seizure, coma. In cardiac, it's chest pain and pulmonary edema. In renal, it's oliguria or rising cret. In visual mein blurred vision and visual loss. Now the causes of hypertensive emergency are very important. First one is the essential hypertension, which is the most common. Secondary causes include the renal artery stenosis, glomerulonephritis, pheochromocytoma is also very important, and hyperaldosteronism. These four you have to rule out. Okay, you have to consider these also if the patient is not having essential hypertension. And if patient has essential hypertension, he can be managed with antihypertensive, but these cannot be. Okay, others include the cocaine use, amphetamine use, monoamine oxidase inhibitor use, interactions, eclampsia, and medication non-compliance. So the common causes of hypertensive urgency include poor medication adherence, patient is not taking proper dose, not taking proper frequency, drug at the proper frequency, and these kind of things, and Also, inadequate antihypertensive therapy, anxiety, pain, acute alcohol withdrawal, and stress. These are the causes of hypertensive urgency. Now we are going to manage the patient. You have a patient in your emergency or in your GP clinic. The patient is having high blood pressure. You check the blood pressure of the patient and it's approximately above 180 by 120. So how you are going to manage? First, you have to check his airway. ABCD approach is the gold standard and the initial most in every case. So you have to go for airway, breathing, circulation, neurological assessments, and exposure, and evaluate for end organ damage on history. From head to toe, you have to go. In history, you have to assess the duration of hypertension, medication compliance, and symptoms of end organ damage. Like you are going to ask about chest pain, you are going to ask about dyspnea, you are going to ask about neurological symptoms like severe headache, diplopia, and other symptoms like and also you have to ask about visual symptoms like visual symptoms, and pregnancy is very important. You have to rule out preeclampsia, and eclampsia. On physical examination, you have to check BP on both arms, not the single arm. You have to check heart rate and respiratory rate and look for end organ signs, including the pulmonary edema, neurological deficits, papilledema, heart failure signs, and aortic dissection signs. Investigations you are going to have these are most important. At least you have to do these. These should be done in every patient you are having with a hypertensive urgency or emergency. Just you have to rule out that the patient is not having hypertensive emergency, so you have to go for CBC infections. You have to rule out some infection which can cause increased blood pressure. Urea creat is important to rule out renal involvement or renal end organ damage. Electrolytes similar, and then TROP for acute MI, urine analysis for also for glomerulonephritis or kidney injuries, ECG for heart, and X-ray for pulmonary. Then CT brain, if patient is having neurological symptoms, then you go for CT brain to rule out brain damage, and echo also, and these CT angio. But at least you have to do these. And fundoscopy is also very important to rule out eye damage. And grade 3 and grade 4 hypertensive crisis, hypertensive injuries are very important. In grade 3, there are cotton wool spots and flame hemorrhages. And in grade 4 are papilledema. So papilledema is a strong suggestion or suggests hypertensive emergency. It is also an end organ damage. So the management of hypertensive urgency. Now we are going to manage. So hypertensive urgency, there is no need of ICU and no need of IV antihypertensives, and the goal for BP reduction is 24 to 48 hours. And how much we will reduce? 25%. So the drugs for hypertensive urgency include captopril, amlodipine, labetalol, clonidine, and avoid rapid BP reduction. Also, when we are managing hypertension, there is a rule of 55 years. If the patient is less than 55 years, then you go for ARBs or ACE inhibitor. Okay, and if patient is above 55, then you go for calcium channel blockers, CCB. Okay, and then you just add on. If the patient is having not controlled, then you add ARBs in this or calcium channel in this, and then third is beta blockers. Okay, and combination therapies. Why rapid reduction? Now question is why rapid reduction of we talked that 25% of reduction is done in the initial hours, in the especially in the hospital. Why rapid reduction is not done, and it's very dangerous? Because when there is rapid BP fall, this may cause stroke, myocardial ischemia, acute kidney injury, and due to impaired autoregulation. Also, if the patient is having a stroke, so this is the area of stroke, for example, hemorrhagic stroke or ischemic stroke, and the area around this is called penumbra. When there is rapid reduction of blood pressure, this results in one thing is that we have to save blood pressure, okay. We have to reduce the BP, okay. But when there is reduction of blood pressure, rapid reduction, then this ischemic area can increase because the blood supply of this penumbra is compromised. That's why rapid reduction of BP is dangerous. Also, it can cause myocardial ischemia and acute kidney injury because the blood supply to these organs is also compromised. Now we're talking about the management of hypertensive emergency, which we have talked earlier also. Includes ICU admission, continuous BP monitoring is very important, and we use IV antihypertensive and treat underlying cause. Okay, so BP reduction, as we talked earlier, in first hour it's 20 to 25%, and then 160 by 100 within next 2 to 6 hours and gradually normalize in 24 to 48 hours. And the common IV antihypertensive include labetalol, very important. Mostly we use nicardipine and all others. Okay, so labetalol is mostly used, and most one thing you just have to remind it is and that appropriate dose of labetalol should be used. Once I was in the emergency department and I had a patient, he was having only this much BP. He was referred from a clinic or I think so other hospital, and they have just given him labetalol 10 mg on this BP. Never prescribed. This is not neither it's a hypertensive emergency, not hypertensive urgency. So there is no use of using this labetalol. You just give him ACE inhibitor or ARBs. Okay. So hypertensive encephalopathy. The features of hypertensive encephalopathy include headache, confusion, vomiting, and seizures, and the treatment include nicardipine, labetalol, and gradual lowering BP. In acute ischemic stroke, if thrombolysis is planned, then BP should be less than 185 by 110, and if not, then the BP treat only if BP is above 220 by 120. And in intracerebral hemorrhage, the target BP should be systolic BP should be 140 to 160. This is a MCQs also and is very important. And preferred are nicardipine and labetalol. Now acute pulmonary edema. So the drug preferred are nitroglycerin and loop diuretics to remove the excess fluid in the lungs, and also we avoid large IV fluids because that can precipitate acute pulmonary edema. Now there is a acute coronary syndrome. We prefer nitroglycerin and beta blockers, and the goal is to reduce myocardial oxygen demand. In aortic dissection, which is a true emergency, reduce BP rapidly. This is important. Only in this condition we reduce the BP rapidly, and the target is systolic less than 120 and heart rate less than 60. Preferred are esmolol and labetalol. Then vasodilators. Now in eclampsia, preferred are labetalol, hydralazine, and nifedipine plus magnesium sulfate. This magnesium is very important in management of eclampsia because it avoids the excitatory neurons and results in avoiding convulsions. And now this is a hypertensive crisis in renal failure, so we use nicardipine and clavidipine and avoid nephrotoxic drugs. The complications include, if untreated, include stroke, MI, heart failure, renal failure, blindness, and death. We already discussed these. So revising the management of a hypertensive urgency and hypertensive emergency. So first of all, you have to confirm that the patient has BP above 180 by 120 in both arms, and then we go for a history of the patient. And in history, you have to confirm the frequency of for how long the patient is having hypertension and what medications he is using. Then we have to rule out the acute or end organ damage signs, and then we have to go for if we find that, then we go for investigations including the CBC, LFT is also included because and then RFTs, serum electrolytes, then urine analysis, and then TROBI, chest X-ray, echo, ECG. These are important, and fundoscopy also very important. And then we go we decide that if the patient is having hypertensive urgency, then we have to give him oral antihypertensives, which include we have used that rule of 55 years old. So we use ACE inhibitors or ARBs like captopril and amlodipine, or above 55 we will use calcium channel blockers. And if the patient is having a hypertensive emergency, then we have to go for ICU admission, regular monitoring, and we use IV antihypertensive like labetalol. Thank you so much.